Well, hi, everybody. Good afternoon. As you know, I'm Suzanne Fasella, and I run Caregiver Haven. And if you want any more material on that, go ahead and look at caregiverhaven.com. But what's exciting is, especially for the members, and we're talking exclusively to you today, we have been talking about medications. And as you know, in the members only Mastermind Club. We've been talking about why medications are so important, how to deal with your medications for your loved ones, and what to do, what you need to know, what you really should be concerned about. So, following along that same thread, I have invited, and he has been kind enough to join us, is David Finley. David is a pharmacist intern. Is that correct, David? Is that right?
Yes. Yes, ma'am.
Pharmacy
That's perfect.
intern.
Yes.
And you're currently studying at Marshall?
Correct. Yes.
Correct. Okay, Marshall University. And he is willing to join us today to talk about medications and what you need to know. So I have several questions for you, and as many of you know, if you have any questions and you want an answer, just go ahead and type them in the chat. We'll be glad to answer them for you. All right, so David, I've got a couple of questions for you. One of them is, I know as a physician assistant, I'm very careful about the type of drugs or the dosages of drugs that I give to the elderly. Can you explain to us why that is so important?
Absolutely. So many years ago, a document came out known as the Beers List, which is basically what, as a pharmacist, we use to make sure that a patient is either at the geriatric level, it's safe to prescribe them that medication. And as you know, I'm sure you use the Beers List when you deal with geriatric patients. Um, so there's that aspect because as we age, we have decreased water and potentially decreased like liver function and things of that nature. Um, so it's very important, especially as we age, because 44 to like 60% of patients of that geriatric age are going to be more than likely polypharmacy. So to have any more than 5 medications for things like diabetes, for potential COPD, potentially cardiovascular health and things of that nature. So you're combining polypharmacy, so multiple medications, you're combining your age, you're combining things such as kidney function. So for things such as metformin, your serum creatinine and your GFR. If it gets too high, we can't dispense or prescribe you medication such as metformin anymore because there's a potential of actually doing more harm than good. I actually had a patient a couple of months ago who came in and talked to me about that. And he said, hey, I think it was, he said his aunt, and this man was probably 55, 60. He said, hey, my aunt swears off metformin. She said it's going to wreck my kidneys. It's going to kill my kidneys and it's going to ultimately kill me because she had a bad reaction to it when she was on it. And he said, what can I tell her in order to not have, to get her off my back, basically, is what he was asking me to say. Like, how can I explain it to her in simple terms? I mean, obviously. But so I told him, I said, your serum creatinine is within normal range. It's around 1.0, and that's what we're shooting for. Anywhere between 0.9 and about 1.2 is normal range. We can get up in terms of metformin up to about 1.5, 1.7 is really pushing it. And of course, it depends on the pharmacy or the hospital pharmacy policy. Like anything in this world, everything has got to be a policy or an operating procedure. But I said, once we get up to about 2, that's where we're going to start getting worried. And about 1.7, 1.85, we're going to be decreasing your amount because it can, have reverse effects and start hurting your kidneys. But right now you're fine. You don't need to worry about it. You've been on the medication before. You've been on it for a while, and you're doing great with it. Your A1C is perfect, well, perfect-ish. Your blood glucose is fine. Everything checks out. You're within normal ranges on everything we're wanting you to be. So if it starts getting worse and we start seeing signs of kidney injury, that's when we're going to decrease it. But until then, it's not going to hurt it at all.
So this patient and many of the caregivers that I work with are always concerned about what these drugs are doing to their loved ones, and they see changes. So, is it common practice for the physician, for their doctors to run these labs periodically and watch the kidneys, watch the livers and liver, changes and see what's going on with the patient, and then they adjust the medication accordingly?
Absolutely, especially if you're uncontrolled, again, to speak to diabetes. So, every 3 months we have to get an A1C. And while we're getting your A1C, we're also going to get your serum creatinine. We're also going to get your GFR, because those are things you can't exactly measure at the house. You actually have to get blood work done.
And the GFR and the serum creatinine is for kidney function. Is that correct?
Correct. It's basically telling us as healthcare providers how well your kidneys are doing and how they are basically functioning. So if we see, you start getting too low, and you'll see that definitely in stage 3, stage 4 kidney disease is where you're going to see a GFR. I've seen it as low as 10 in a patient before, which was pretty scary. But yeah, so you're going to see a decrease in the GFR, because I want to say above 60 is pretty much a good range for medications. Below 60, most medications are still going to be okay. And it also depends on, each individual medication, because some medications may completely bypass the kidneys. Other medications, are specifically targeting the kidneys. And that's where you're going to have to be worried about it decreasing to the point where we can no longer give you a medication. And you'll see that very commonly with diabetics.
And that's because the kidneys process and metabolize and then excrete what drug isn't used. Is that correct?
Yes. Yeah. It basically, I like to think of it like a filter. And that's basically what it does. It filters out whatever is in the bloodstream, and then from the bloodstream, it's going to go and be sent out.
So basically, if you give a drug and it either hurts the kidneys or the kidneys aren't functioning properly, that medication could build up in the blood and be toxic.
Yes, actually, it could. There was an old saying that I'm reminded of to that point, where any medication is a poison. It just depends on the quantities or the amount. Because, you can overdose on Tylenol, and Tylenol's been taken for centuries with no issue. But if you take too much of it, you're going to go into acute liver distress. So that's how I like to think of it. And that's why we have to do all these tests and stuff like that to make sure that, we're not producing an effect that may cause patient harm, which is kind of the opposite of what we want to do in the world.
Yes. Yeah. So, and again, do no harm, right? So we're giving a medication. We want to make sure that, trying to cure somebody or fix or maintain their systems, make them better without the side effects of making them toxic, I guess.
Exactly.
All right. So many people ask me, and you can answer this better than I can, what is the difference between a generic and a brand name?
Okay. Yeah. And I've gotten that question a few times too, because, and this will, it's pretty simple. The FDA requires that generic medications have the same medication in it, the same active ingredient. So Tylenol versus acetaminophen. The only difference is that acetaminophen is definitely the brand medication, but it's still the active ingredient in both. And brand medications, you're going to see the incidentals, things such as fillers may be different, a proprietary blend that the makers of Tylenol add to Tylenol specifically that you're not going to see in a generic medication. But in terms of government regulation, they are functionally and legally required to be the exact same thing.
Well, I heard, and I always thought that it has the same ingredient. If you take Tylenol, you have the same ingredient as a generic acetaminophen. However, I've heard that the amount could be different. So a generic could be 80%, but a brand name has to be 100% of what it's saying it is. Is that correct?
No, So for instance, let's use Tylenol. Tylenol 325. It's your OTC standard run-of-the-mill Tylenol that you're going to get anywhere at any store. Generic, say CVS Tylenol that I'm not sure what exactly their generic CVS brand is. But 325. 325 is 325 is 325 at the end of the day. So it's going to be the same strength. Ibuprofen versus Motrin. 200 milligrams. 200 milligrams is 200 milligrams at the end of the day.
Okay.
So it's going to be the same strength and quantity in that medication. You're not going to see somebody say, well, Motrin 200, and then see a generic of Motrin 150, and that'd be acceptable and can, having them the same like strength and weight. No, that's no, because at that point you're two different medications.
Well, what about something like the thyroid medicine? Because we in practice have always thought that we were supposed to give Synthroid versus levothyroxine, I guess it is, right?
Yeah. So for instance, Synthroid, one top 0.88 micrograms.
Micro, little tiny bits.
Yeah, way bit. That gets into a whole measurement system that I like to see what I'm doing, and at that point, I feel like you're just guessing. But it's still going to be the same strength of medication, because if you think about it, it kind of has to be, because at the end of the day, if you're doing two different things, or sorry about that, if you're doing two different strengths of medication, well, that's two different strengths of medication, and you're not able to really measure properly and safely if you as a physician writes for Synthroid specifically, and then we're legally required, at least here, to give you the generic version if possible. So if you're writing for one thing and thinking that the patient's going to fill that, and then they're going out and getting generic of a different strength, you're going to be chasing the illness. You're not actually going to be treating it.
True. I see what you're saying. We're not going to get ahead of it.
Exactly.
So I think most states do have the pharmacies use the generic brand versus the brand name, because in theory, it might be cheaper, or there's a contract between the insurance company on what they will pay for specific drugs and the policyholder, I guess, the patient themselves.
Yeah.
What they'll have. So in doing something like that, the generics versus the brand name, it's rare that somebody, why get the brand name then? Why pay more?
Like I said, the incidentals. So for instance, take something like Adderall, ADHD medication, pretty ubiquitous out there. If you are on Adderall or Adderall XR, and you are also on methamphetamine, or not methylphenidate, which is Ritalin, versus Ritalin, for instance. Incidentals are going to be the difference. So
incidental?
Things such as fillers.
Oh, okay.
Yeah, I know that. So, and this goes to this topic, and I'll get around there if you'll humor me for a second. So we have patients who are drug seekers, for instance, and they will come in for cough syrup, the hydrocodone cough syrup. Well, there's a couple of different brands of the hydrocodone cough syrup, and we'll have patients say, oh, I can't take the purple one, I can only take the green one, or vice versa. Problem is that because the purple one in this instance is easier to break down, and you're easily able to pull out all that stuff that is presenting potential drug abuse, versus the green one. And because it's easier, patients will suddenly say, well, I can't take that one. I've got to take this one specifically. So you'll see it.
Break it out.
Exactly. So that's a roundabout way of basically saying every medication will affect people differently. So some people can, take the brand name only because whatever they add in as a filler is what's allowing them to actually process and get the medication into their system better, versus the generic, which may not have whatever the brand name manufacturer is making in there and able to process it and metabolize it efficiently.
Interesting. I remember a story years ago about the United States Army. This was back like World War maybe one or two.
Mhm.
And our boys were going out on the nights they were in port, and they were picking up syphilis. And the Army realized they had a real problem with syphilis. And so they ordered up the penicillin
Mhm.
to get rid of it. And before they bought like $1 million worth of penicillin for the United States military. And remember thinking this is back in World War I, possibly World War II, I'm not sure. A lot of money. And the United States government, being the responsible people they were or are, said, we're going to check it and make sure that it's really a good ingredient and is very active. So they did. They took it to a lab and they looked at the ingredients of penicillin and they said, yes, it is active. It can kill the syphilis. We'll go ahead and do it. But they picked the cheapest company to make it. Come to find out, the military is not getting better. The guys were still having syphilis. And it wasn't the ingredients, it was the capsule that was not breaking down. And it took a guy in the, you've been in the military, the guy that does the cleanup in the kitchen, that guy that saw the capsules in the, well, maybe not the kitchen, I mean the Johns or what, saw the capsules, and they weren't degraded, let's put it that way.
Oh, he saw ghost capsules. So similar to what you see with Vyvanse, that's something we actually have to tell patients.
What?
Like, hey, if for some odd reason you decide to, check your bowel movement after you're done and you see a capsule, it's okay. The medication is actually in your body. Don't think that, I'm just passing it completely through.
And that's called a ghost capsule?
Yeah, it's a ghost tablet or a ghost capsule. Yep.
That's
really fascinating. I don't know, again, to speak to your, I think they would call them custodians or janitors, not necessarily, a cook in a kitchen.
Yeah, I'm sorry. I don't know.
But,
sorry about that. That's
yes, so, some patients do, some patients don't, but we have to tell them, hey, just in the odd event that you do, and I've had to tell patients like, hey, FYI, you may see this tablet, and they would just look at me and say, why would I be going through that? And I'm like, I don't know what to tell you, but in the odd event you do, FYI.
That's right. Sometimes. Very much so. Well, one of the things that we talked about in this week when I gave the ebook to the Mastermind Club members was we talked about medication review. And we talked about something called, I got to get it here, medication reconciliation. And I explained to the members how they could take their loved one's medications to a pharmacist, set up an appointment, take all their drugs, including over-the-counter drugs. Because I am adamant about over-the-counter drugs. Even Benadryl was a prescription back until 1985. You couldn't get it without a doctor's prescription. So what I'm saying is all these medications over the counter, like you indicated, have potential side effects or toxicity. So I want the members to take everything to the pharmacist. Is that what medication? And then what do you guys do as a pharmacist? And are you willing to do this?
Yes, actually. And to speak to that point, so there is the MTM, which is the medication therapy management. So basically, as a pharmacist, what we would do is you would come in, or now because of COVID restrictions and all that, and patients who have ambulatory issues, we would either in person or over the phone have you gather up all your medications. And basically what we're trying to do, think of an umbrella. So, you have the points of the umbrella on the outside, right? And they
Mhm,
all come in to that middle handle, I guess you would say.
mhm,
Think of it like that. You're having all these different teams of providers. You've got providers, let's say your cardiologist,
mhm.
and then let's say patients who are being seen for cardiology are also being seen for diabetes in the diabetes clinic, potentially like INR and blood work and all that stuff. And you're getting all these medications for it.
From different doctors all over the place.
Exactly. And,
Exactly.
you've seen at the hospital. And well, now suddenly, you've got all these medications that you received at the hospital.
Mhm.
And now you're going out and saying, hey, your local doctor, and I'm not sure how it is in Florida, but your local doctor may not necessarily have the ability to access records
Right.
that you received from a hospital somewhere, especially if you have to travel a few hours away because there's only so many hospitals here. They don't necessarily talk to each other.
Right.
And
They
it can
do
be
not.
kind of frustrating as a patient to say, hey, I've got all my paperwork, but they didn't give me discharge paperwork. So I don't know what I received while I was in because I was out of it or whatever.
Mhm.
So as a pharmacist, what we want to do in terms of MTM is have patients be able to streamline that process so that we can look for potential. Do you really need to be on this medication? Is there some way that we could save you money by not being on X, Y, or Z? And interactions, because one pharmacy may not necessarily talk to another pharmacy, especially if you're paying cash.
Mhm.
Um, I've seen this before where a patient will pay cash for a medication and it won't pop up on whatever when we go to bill insurance, and insurance will reject something because it's filled too soon. But
Oh,
if
okay.
it's filled too soon and you've paid cash, I might not necessarily see that because of where I'm located in a tri-state area of Kentucky, West Virginia, and Ohio. So if you go to Columbus and get something filled, and then you come to Kentucky and get something filled, or West Virginia, or wherever, I might not necessarily see that you filled something, which as a family member can be very, scary, especially if you have something like Alzheimer's and you say, well, I'm on these medications and I forgot to fill this one, I forgot to fill that one, and in actuality, you didn't. So all of a sudden you may be doubling up on your medications, which is a whole other issue. But so what we do as an MTM is basically try to break it down for the patients and their loved ones to the most streamlined, efficient, and safe, ultimately, uh, way of going about your care and your care plan. So we're able to talk to you. We're able to talk to all these other doctors and stuff like that. Um, in terms of where you can get this done, there's multiple different companies. And then for pharmacists, we actually have to be specially trained or licensed as a MTM pharmacist. And that's what we do. Like that's in terms of a CV, that's our number one bullet point, MTM pharmacist. CVS, Rite
Mhm.
Aid, Walgreens,
Mhm.
you just have to call, for instance, here we've got CVS is the big one here.
Mhm.
You just call the CVS and say, hey, I would like to schedule an MTM appointment, and they'll set that up for you. For older patients, it's all covered by Part D
Mhm.
of Medicare. For younger patients, if you're a polypharmacy patient, usually insurance will cover it. So there's no out of pocket cost for you, which is really nice. For pharmacists, they found that there's usually about a $4 ROI, return of investment.
Mhm.
So it's beneficial for pharmacists in terms of a monetary standpoint.
That's nice.
Yeah, exactly. And, for 30 minutes, 45 minutes to talk with a patient to make sure that, everything that they're doing, it's being done correctly. Because, at the end of the day, we want our patients to be safe and healthy and have a good quality of life. And that's where MTM allows us to have a better impact into that.
And that stands for medication what?
Medication treatment management or medication therapeutic management.
Okay. And so it's no cost to it's no cost to the caregiver to take their loved one and get this done. Or do it over the phone if they can't go out, or a Zoom. But is there, now pharmacists can't take a patient off or put them on a different medication, correct? You would
That
have to call the
varies.
doctor?
That varies between state and state, and as
Okay.
well as what system you're involved in. So for instance, I'll give you an example. So I recently had an 8-week intern rotation at the VA, Veterans Hospital, VA, Veteran Administrative Hospital here in Huntington. It was really nice because in my capacity as a pharmacist, I was able to, and my three fields of practice were diabetes, hypertension, and cholesterol.
Okay.
And so if, let's say, for instance, you're a veteran, you come into the doctor and your A1C is, I saw it up as high as like 16 in a couple of patients. Yeah, it was a little,
Yeah.
but so let's say your A1C is not decreasing with your doctor prescribing you metformin. And they say, okay, we are going to recommend you go see this clinic. And it's nice because the clinic was on the same floor as the doctor's. So I could stick out my head out of the door and yell at the doctor if I wanted. I obviously didn't,
Yeah.
but I could throw something at him if I wanted to. But so patients would then still go see their primary for whatever issues else they had going on. But then they would come to me specifically and say, hey, here's what the doctor has had me on, here's my blood labs and everything like that. And I could say, okay, well, obviously your metformin's not working, so we're going to increase it. And on top of that, we're going to add something like glipizide, or Ozempic is one of the hot new ones, or Jardiance, also hot new medication. And I didn't need any outside intervention from the doctor to say, okay, I agree with this, or no, let's try this, because they knew that was my point of specialty care. That's what I did all day.
Is this universal throughout the VA?
Yes, as far as I know.
So that's kind of nice. A veteran can go right down the hallway or to the office of you, where the pharmacist is, and say, hey, or even set up a time to go over their medications and say, okay, this is what I'm doing. And you have access to their labs and what's working and what's not working. Is that correct? Yeah, that's really nice.
Absolutely. I would be able to contact them if something came up all of a sudden. I could check on them. It was basically, I was a provider in the capacity that I am a provider without needing outside input. And, the patient still seeing the doctor. So the patient or the other providers can see what I'm doing specifically to try to treat their hypertension, or try to treat their diabetes, or try to treat cholesterol, or whatever in my capacity.
Man, what a teaching moment. I had no idea that medication reconciliation was so much more, because then you get to understand what the drugs are doing, because many caregivers will complain that they take their loved one to the doctor and it's a 5-minute visit. It's an hour wait, a 5-minute visit. By the time they get to the parking lot in the car, they forgot what the doctor said, and they don't know why their loved one has another medication and another medication. And you talk about polypharmacy, where they're on many medications. And the caregiver's like, no, I just wanted somebody to hear me. I just wanted somebody to listen. And yet they could, in the VA system, they can walk down the hall and see a pharmacist. And we can do that even outside the VA system by just picking up the phone and calling a pharmacy, preferably the preferred one by the health insurance policy, right? And say, can I sit down with you and can we do this MTM? That's really good.
Absolutely. And to go to your...
I'm going to change the subject up on you a little bit here, David. Let's say that my caregivers are getting ready to throw out drugs. They've gone to mom or dad's house. They live alone, and there's 20 years worth of medications in the closet or in the cabinets, right?
Mhm.
They need to throw them out. What is the safest way to throw out medications?
Okay. So there's a few ways, but it's basically all the same system. The first one is you're going to want, if you have, I personally don't drink coffee, but I've heard a lot of people do. And if you have your coffee at the house or at the home, coffee grounds. If not coffee grounds, something like kitty litter.
Okay.
Basically, something that's going to dissuade animals or people to get into the medication.
Mm-hmm.
Um, so you're going to want to first get it wet because, as we know, medication breaks down for the most part. We're talking tablets and capsules. Things like patches are a different thing, and I'll talk about that briefly after this. But tablets and capsules dissolve. You're going to want to dissolve them. And then once they've been dissolved, either in a plastic baggie or the bottle, whichever is easier. If you don't necessarily have a plastic baggie, you can always use the bottle.
Mm-hmm.
Put the medication in there, add water, make sure it dissolves, and then add something like again, the coffee grounds and things of that nature. And then once that's done, you're going to want to seal it.
Mm-hmm.
And then you're going to want to basically dispose of it. If you're using a bottle, you're going to want to obviously remove any identification, like any identifying information,
Okay.
name, date of birth, last four of the social, what the medication is, things of that nature.
Just take the whole label off the
Yeah,
container.
exactly.
Yeah.
And, I don't have fingernails. So usually a marker is the easiest way for me, or a pen, and just scratch it out.
Mm-hmm.
And then basically throw it away. You don't want to dump anything down the sink, which I get is a lot easier, or, throw it away in the toilet. A
Sure.
lot easier. But, that's how you end up with seeing occasional stories about fish
Oh,
having
okay.
ingested large amounts of, let's say, birth control, and affecting a certain population of fish.
Yeah.
Um, Now, along with that, in terms of patches, so for instance, fentanyl patches,
Yeah. Fentanyl. A
those
lot of
can be,
older people probably do have fentanyl patches
yeah,
for pain, right?
exactly. Those can be just regularly thrown away because there's really not much you can do in terms of dissolving them because they are heat based and heat activated.
Oh, okay. That's good.
So your best bet with those would be when you throw them away, and you don't want to really touch them, because if you touch, the tablets and the patches, they can get on your fingers, and then all of a sudden, you're minding your own business, and you're like, oh, now I'm suddenly dizzy. I mean, obviously that's a facsimile, but those can just be thrown away because there's really not much you can do to destroy those without potentially putting yourself in harm, which we don't want to do. Those can be flushed because since they're not, they don't dissolve per se with water, which would be pretty pretty bad if you were, out swimming, minding your own business in a pool with a bunch of people, and all of a sudden everybody, I joke, but it's never happened to my knowledge, which the things I don't know could fill an ocean. But those can be flushed, disposed of, or they can be thrown away.
Okay.
If you do want to flush them, for instance, used ones, uh, basically you want to just fold it in half,
Mhm.
sticky side to sticky side, and then throw them away or flush them down the.
Do you still need to use gloves when after they've been used?
Usually for patients, if you're caregiving and you have gloves on, yes, because that residue again can get on your hands. I have seen a few cases of accidental ingestion,
Mm.
usually with, for instance, a family goes and visits their loved one at a nursing home,
Mm-hmm.
and it's more of an independent nursing home, so the patient is able to give themselves their own medication. Specifically, a case that I've been involved with was a little boy was driving his truck on the rug in his grandmother's room, and everything was fine. Family went home. All of a sudden, the little boy passes out and becomes unrevivable, quits breathing, and ultimately dies. What ended up happening, we found out, was that um, the little boy's grandmother, she wasn't throwing away her fentanyl patches. She wasn't closing them and properly disposing of them. And one was on the ground when the little boy was riding his, pushing his truck around her living room. He ended up, as little kids do, taking it, putting it into his mouth and chewing on it.
Oh.
She activated, ended up ODing, and human bodies weigh, or not human body, but an adult body, even geriatric, versus a little 3 or 4-year-old toddler. It ended up causing respiratory depression and ultimately death related to that.
How sad.
Yeah, it was pretty bad, and we ended up writing a whole bunch of SOPs and talking to patients about how to properly dispose of all these medications.
Sure.
Because we don't want something like that to happen. Medications are fantastic, and at the end of the day, they're designed to improve your quality of life, but they can potentially also harm you or unintentionally harm other people. So yeah, but that's how I tell my patients to throw away their medication and get rid of it.
So what about creams?
Creams are a little different. The best thing to do with creams, because you're going to want to remove the information, obviously. You don't want grandmother's name, grandfather's name, or your name out there on some random bottle that you no longer have control over, especially nowadays with having your information stolen, potentially. So remove that identifying label in any way, shape, or form you can. Creams are a little bit more tricky because you can't exactly, open up a cream dispensary tube and then throw it away, because cream's going to get everywhere. It's going to be a mess. What I tell my patients with that is to remove all your identifying information and then just throw it away.
Okay.
Ideally, it's not the best thing you can do, but if you think about it like a toothbrush or toothpaste, once you're done with the toothpaste, you just throw it away and go get a new one. It's really about all you can do with creams, ointments, lotions, and things of that nature.
How come drugstores don't take back products? Medication?
It's a safety issue for us. No, we do. We have certain. I know when I was in and I was practicing, we had certain days that the sheriff's office would come out and set up a box, and you could then properly dispose of your medication in the pharmacy.
Nice.
But if you think about it, let's say you're a patient and you bring me back something in a bottle. I don't know what it is. Well, if I don't know what it is, you're just saying, here, I have this, I want to get rid of it. I don't know what it could be. It could be something as innocuous as, I don't know, acetaminophen powder. Or on the other hand, it could be anthrax. Like, obviously that's a wide range of things, but I don't know for sure what it is. And I mean, I say that with a smile or a smirk on my face, but I'm sure you remember of when politicians were receiving white powder in envelopes.
Yeah.
I'm not really, a few years ago. And they didn't know what it was. Come to find out it's anthrax. Well, now you've just breathed in anthrax. So from a safety standpoint, I don't feel comfortable with you bringing back medications, And then from a health standpoint, if I don't have a proper place to put these medications, which every pharmacy I've ever been to always has a place to put this expired medications and stuff. Right. But if I don't have something like that, and you bring in, let's say, an EpiPen, and if I get really rushed and I don't pay attention, I could now just dispense out this EpiPen to somebody that's expired.
Yeah.
To my knowledge, it's never happened, but I like to say that safety regulations are written in blood, because they've been written because something has happened.
That's
and
right.
so
Well, that makes sense, because that was my next question, why pharmacies won't take back medications. Like, just the other day, I had a patient come in and she was not breathing well. And
Mhm.
I had to pull out basically all stops to get her breathing again, which I did. But she'd been to another medical provider, and that medical provider had really, I didn't tell her, but I would have used a different medication for her to get her
Mhm.
breathing. And she said, my gosh, I just bought all these medications at the pharmacy. Are you telling me that that was just a waste of money? And I said to her, no, you may be able to use them later on. I'm just trying to get, basically, she was having an asthma attack. And I had to get her under control. She was not breathing. And having experience in the ER doing this, I knew what I needed to do, and I had everything with me. I could do it in the urgent care versus sending her over to the emergency room. And I don't know how much time she would have had there. I really don't. So I did. I got her under control. I got shots in her and everything else, and prescribed better medications for her that I knew would control this asthma and not bring it up again. I say that because she was frustrated. Here she was. I was more worried about her breathing. She was like, did I waste all this money? And I know that pharmacists can send things back to their distributor, who then sends them back to the manufacturer. Because as a
Mhm.
pharmaceutical rep, I used to take tons of stuff back from the pharmacy and give credit to the pharmacist or the pharmacy for it,
Yeah.
from my pharmacy, from my company, my pharmaceutical company. So couldn't there be a way that pharmacists can give people back their money?
Not necessarily give them back their money. Medications are interesting because let's say you go shopping and you buy some clothes and that you don't like them, you're able to return them for store credit. Can't really do that with medications,
Oh,
because if you think about it, such as um, police and evidence, everything always has to be documented, and if it's not, and something happens to it and then comes back, you evidence
it's
anymore.
it's a chain of custody.
Exactly.
Okay.
And once medications that I give you leave my store, my window, what have you, I no longer have chain of custody. So I can no longer prove that what you say you're giving me is what you're actually giving me. If you're buying medications from me for $5 and you go out, you change the label on it, you bring it back in and say, I want store credit. Medication you brought in all of a sudden is $50. It's a store credit of $45. That wasn't necessarily, on the
Mhm.
up and up. And also, when you bring any medications in, we've all seen in the news people robbing pharmacies. It happens from time to time here, um, at the very least. If somebody wants to rob a pharmacy and they know that medication takeback's a thing, around here we have a very large geriatric population. So you are going to see things to improve quality of life, such as, like you said earlier, like fentanyl or pain medication. Well, if you're having somebody come back to the pharmacy wanting to rob it, and they know for a fact that, you know, people are bringing back in pain medications,
Mm.
be more, they might be less hesitant to break into a pharmacy that doesn't do that versus a pharmacy that does.
Yeah.
So
Well,
it's
they
a
would
safety
know.
standpoint in terms of, you know,
Yeah, that
it's a
makes
safety
sense.
standpoint for a pharmacy, both.
Hmm.
So ideally, yes, at the end of the day, would I like to see something like that where in your medications to that pharmacy, I can take them without any issues and store them somewhere
Hmm.
and then be able to refund your money? Ideally, yes, because I mean, I've got to pay for medications too. I'm well aware of how expensive they can get. But from a safety standpoint, from a legality standpoint, I'm much less hesitant the way things are right now.
Sure. And I'll tell you though, with medications being as expensive as they are, it's so frustrating. I had a patient the other day tell me she's spending $302 a month just on one medication. And I hate that for her. Her insurance is paying the rest. And I understand that pharmacists want to do customer service. So ideally, it would be nice to have you give the patients back their money, but
Yeah.
you can't take the medications back either. You can't for that reason.
No. What I do tell patients when they do want to bring back in their medications, and some of them after they're done yelling at me for not being able to take it back,
No.
I'm extremely apologetic. I'm sorry, I can't do this. Sheriff's offices will accept medications.
Okay.
Yeah, at least around here. And, for you and people reading, they could go on their local sheriff's website or give them a call and say, hey, do you all accept medication takebacks and stuff like that?
Old medications, sure, or whatever. Yeah.
Yeah.
Well, that sounds good. Well, those are about all the questions I had, and we're going to be a little out of time here in a few minutes. I can't thank you enough, David, for giving us this valuable information. I know that so many people ask these questions and just wonder, and they don't know where to start, and they really don't know their pharmacists like they would like to know them, because you're in the back, we don't see you that often. We see the farm tech a lot, and we have these questions, and then you have to stop what you're doing back there, come around to the front, answer the questions, go back. And I know on any given day, you'll dispense how many prescriptions in a day?
Let's see. When I was, the most I had ever dispensed was around, and this is specifically for me, probably my numbers had around 500 medications in a 12-hour shift. Thankfully, on the civilian sector, community pharmacy, CVS, and stuff like that, it's a lot less. Usually, we'll see 200-300 for the entire pharmacy for that day.
That is unbelievable.
Exactly.
That is unbelievable, and you can't rush it either, because it's still got to be counted. It's got to be labeled. It's got to be documented. It's got to be right. It can't be wrong. You can't be 99% correct. You have to be 100% correct.
Yeah, which is funny because we're taught that, and as a healthcare provider yourself, that we're told that we have to be 100% perfect every single time we see a patient. But then as a human, we're not 100% always correct. You know what I mean? So it's a very tricky thing to try to wrap your head around as providers, saying, oh, I've got to be 100% correct all the time, but then know that that's not that's not an actual possibility. We do the best we can, obviously. Like, nobody in the healthcare field wants to cause patient harm.
Right.
But that's why we have so many different checks and more checks and more checks. Blood work, and I feel something, somebody else is going to check it behind me, and then so that way we can try to mitigate that patient harm impact,
right,
to the point of saying we are 100% perfect as a team, because
that's right.
if I'm having an off day and I make a mistake, somebody behind me might see that mistake. It never goes out to the patient.
Right. It's a good policy to have. It's also a good policy for patients to be advocates themselves, patients to ask questions, to do the medication, what's it called again? MTM?
MTM, yeah, that's what we refer to it as.
I could keep calling it medication review or medication reconciliation. Yeah, it's a good idea to have that done.
Yeah,
and then they get to know you too.
Call up your pharmacy or a provider and say, I want to do an MTM. You could also say, whatever, for instance, what you just said with the MR medication review or medication. Basically, if you just call up your pharmacy or your provider and say, I want to schedule an appointment to discuss my medications,
Mhm.
my therapy or my treatment, or I want to discuss medications and my profile. They're going to know what you're talking about. It's one of those, like, not necessarily buzzwords or catchphrases, but it's, what I call it might be different than what somebody out in, Alaska or California calls it.
Right.
But if you call me up and tell me I wanted to schedule an appointment to do this, I'll know what you're talking about,
Mhm.
even if the words are different, just like medication, what you call a medication, I might not call a medication, because they're all made up words at the end of the day. And some of these things are, 15, 20 letters long.
Oh, it's a whole nother language, especially because these new medications, you can't say what they are. You're not allowed by FDA to call them fast acting glucose, something. You can't. You got to call it mumumaba or gababa or something. I don't know.
Yeah, exactly.
It's interesting. Well, I can't thank you enough, David, for sharing this and all this information with us. It's so valuable. And as far as the members go and the mastermind members and everyone, all caregivers, I just hope that you take a minute, gather up all those medications, pick up the phone, call the pharmacist, set up an appointment. Please see him or her, go over these medications. You will learn so much more than you ever dreamed of. And a lot of times you'll learn why your loved one is acting like they are, why they're either tired, why they're energized, what's working, what's not working. And then go to the physician who prescribed that medication and talk to him or her about how it could be changed if your pharmacist can't do it for you. Thank you, David. I appreciate you. We'll talk soon. Take care. And thank you again.
Well, and if you have any questions, or, if your members have any questions and want to contact you and you can relay those on, I'll certainly do the best that I can to answer those. So yeah, thank you again for having me. It was great talking to you, and have a great rest of your day.
Thanks. You too. Bye-bye.